This is the Medicare model as it is defined today. Further refinement is expected to occur in early 2011 to allow for final submission of pilot projects. Also keep in mind that other payer-driven ACO structures may be different. With that background in place, let's discuss what this will mean to hospitals and what this could mean for orthopedics. Most of the past ACO-type models have been largely driven by insurance products within the health system looking to better manage patient care and costs. However, tomorrow's ACOs will be different from these legacy organizations such as Geisinger, Mayo, and other integrated groups. Tomorrow's ACOs will either bring together very distinct providers into brand new organizations that function with the sole purpose of being an ACO, or they will be existing entities that will be retooled to meet new needs. It is important to recognize that a number of programs across the country are already piloting ACO. They include the Brookings Institute and Dartmouth working with provider systems, each comprised of large group practices and hospitals. Some early feedback from this project suggests that 3 areas are critical to the success of an ACO. First, there needs to be strong physician relationships and the ability to have open dialogue. Second, there must be trust among all parties. And third, payer involvement and support is crucial. Baylor has already begun marketing the ACO concept to employers offering lower costs in exchange for participation in health insurance plans. And in May 2010, Premier launched 2 initiatives. One to help those health systems that already have foundational elements to support an ACO, and another to help hospitals that are in the process of building the capabilities needed to implement an ACO. So with all this movement going forward for ACO, what are some possible roadblocks? The biggest roadblock involves existing regulatory legislation. Anti-kickback and Stark laws are both examples of legislation that is currently in place with the goal of assuring that one healthcare provider is not being paid to provide a referral to another healthcare provider. In the anti-kickback statutes, there are safe harbors for certain relationships. If a hospital is developing an ACO, one of the most direct ways to ensure a compliant relationship is to employ physicians, as direct employment fulfills a safe harbor. At present, the Stark laws do not have a specific exception regarding ACO. 2 other examples of regulatory barriers include the civil monetary penalty and antitrust laws. Since ACOs intend to improve efficiency and limit services, the civil monetary penalty could be another regulatory concern. Also, ACOs, by design, could consolidate a market, thus possibly violating antitrust laws. So in summary, the regulatory barriers are a key area that needs to be addressed for successful development of an ACO. In the past, most Medicare demonstration projects provide exceptions to many of these regulations. It is believed that the Medicare ACO project will be granted these same exceptions. The first step a hospital should take in forming an ACO is to effectively engage their physicians. Without their buy-in, the ACO will not succeed. Even if the ACO does not come to fruition, these physician engagement strategies will still provide value in improving hospital surgeon collaboration in other areas. Keep in mind the following when trying to engage your physicians. In addition to physician concerns about the payment aspects of ACO, they also want to have influence over the care processes that they are involved in. Incentivizing physicians to be involved in an ACO can take many forms, with the biggest benefit to the physicians being improved efficiency for them and their office staff due to better coordination of care. In many cases, a co-management arrangement can be a good place to start this integration process. And finally, quality can be used as a safe and effective platform to begin building physician engagement. In addition to the physician engagement strategies, hospitals should be doing the following to begin the basis for accountable care. As mentioned previously, even if a hospital does not formally pursue an ACO project, these elements will be beneficial to strengthening the care processes. Many of these strategies are foundations of effective service line management. Hospitals will need to change their mindset from a hospital to a health system. This will need to include better organization of ambulatory services. In a service line such as orthopedics, where there continues to be a shift in outpatient services, this is critical. It will also be important for hospitals to strengthen their post-acute care relationships or ownership. In orthopedics, this includes stronger relationships with home care nursing, home care physical therapy, and outpatient physical and occupational therapy. Patient education, along with family education, will need to improve to allow for better organization of care continuums beyond the hospital walls. As discussed in a previous installment of this series, bundle payments will have a more direct impact to orthopedics since bundle payment focuses on defined episodes of care for a single diagnosis. Orthopedic surgical processes and the pre- and post-acute care component fit nicely into this model of payment reform. ACOs are a more global concept that will require a broader range of effort outside of an acute episode of care and more management of the disease health continuum. Even though accountable care is a broad concept that will not directly impact orthopedics in the near future, the tenets and philosophy are important in providing effective and efficient care. The accountable care model will force orthopedics to move over time from an episodic management to a broader disease management base, to include, among others, osteoarthritis and osteoporosis. Ultimately, the programs that adopt this broader management concept and effectively integrate the surgeon, non-surgeon, and ancillary care providers will be the ones that win. For the past 12 years, Accellero Health Partners has been working directly with healthcare providers to do exactly that. Working with hospitals, surgeons, referral sources, and ancillary care providers to develop and improve each element of the continuum of care and strengthen the linkages between them. This is a core principle of Accellero's programs and a key success factor to creating a program that is the clear choice for care in the region. Accellero is committed to helping you and your best customers anticipate and prepare for changes in healthcare. Should you or your customers have any questions related to accountable care organizations, bundle payment, pay for performance, or other prospective reimbursement models, please contact your distributor's designated Accellero Business Development Team member. Our team will be happy to set up a conference call or come on site to meet with you and your customers.
Thank you for attending today's program. For more information on this and other Accellero Advantage programs, contact your designated Accellero team member or visit our website, accellerohealth.com.